you.
Ladies and gentlemen, welcome to this, our 6th UGLE webinar on COVID-19, the silent killer. This is something particularly close to my heart as a practicing physician, and I'm delighted to welcome Dr. Akram Baig, who is a Senior General Practitioner from Wales and has been on the front line with the rest of the NHS over the past 12 months, and indeed for a little chairman of the Welsh Medical Advisory Committee to the Welsh Government. He was a former chairman to the local Medical Advisory Committee for Cardiff and Vale Health Board. He is a hospitaller of St John in Wales. He's chairman of Cardiff and Vale Council, and has a string of experience to be able to take us through this subject. But it's not just him you'll be hearing for. There is a panel of experts that he has assembled to answer your questions and bring their own particular perspectives to this very interesting subject. Ladies and gentlemen, welcome Dr. Akram Baig.
Thank you, David, for the kind way you introduced me. Good evening, ladies and gentlemen. This pandemic has affected us all. Some have had to shield, some to isolate, whilst others have had to work from home. Lockdown has had a huge impact on our lives. Suffering has been widespread due to COVID. Some have lost their lives, others their loved ones. Some have had COVID themselves. Some have lost jobs, others their businesses, and the list goes on. Little was known about this virus when it started. Even doctors were bowled over. Ladies and gentlemen, we have so much more to learn. Tonight, we have some excellent speakers who all have been in the front line dealing with COVID patients. Their experiences in their respective fields will be highlighted what COVID is doing to the patients and to the community. We will tell you briefly about the virus, where it started, how it spread, its diagnosis, treatments, and above all, the variants, vaccine development, side effects, the misinformation and disinformation of vaccines, along with the new long COVID. Some of you may not have heard about it. Vaccines and the interactions with medications, etc., and COVID's effect on mental health. I'm going to kick off by talking about the virus, but before I start, my apologies to some for hearing my repeat some of the contents that I'm going to say, but tonight there's a wider audience here, and for their benefit, I may have to repeat some of the slides you've seen before. Sean, may we have the first slide, please? Thank you. Ladies and gentlemen, COVID, the introduction that I had was a silent killer. On reflection, it should have been an invisible killer. Now, this slide that you see is that of the coronavirus. And this is a magnified specification of the coronavirus that you're seeing. It has all the spikes around it, and these spikes are about 9 to 12 nanometers in size. On the right-hand side is a transsection of COVID-19 seen under magnification, electron magnification. Now, the red dots are the spikes. The yellow two bands that you see are the lipid capsule, and the middle is the protein gene of the virus, the DNA. Next slide, please. Okay, COVID has spread globally, As you can see, this is just a brief slide to show. This slide was made on the 25th of March 2021, and globally we had 125.5 million cases, deaths about 2.758 million. And in United Kingdom, if you look at the third column down, was 4.31 million cases and deaths about 126,000. Since then, the figures have changed. Globally, we have 133 million cases on the 7th of April, with 2.89 million deaths. In the United Kingdom, we have 127,000 deaths. USA, you can see the same thing on the 7th of 4th, 21. There were 30.9 million and about 559,000 deaths. Next slide, please. Coronavirus is not a new virus. It is a virus that's been around for many, many years. It comes from a family tree of coronaviruses, which have got 6 species. These 6 species, the 6th has now divided to make it into 7. 4 of these species are, or strain you may call them, are cause less severe disease, such as the common cold, the sore throats, etc., which we get seasonally. The severe diseases are the SARS, the MERS, and out of the SARS, the variant Covid-19 has come about, also called SARS-CoV-2, which is the present coronavirus that we have got. For the benefit of the audience, I will keep calling it Covid-19 from henceforth. Next slide, please. Now, SARS, severe acute respiratory syndrome, this was the severe one. It always starts in bats into an intermediary host, which is a chouette, onto humans. It started in 2002 and ended up in 2004, killing 774 people. The MERS virus, which is the Middle East Respiratory Syndrome, started in bats, went into camels, onto human beings. It started in 2012 and killed 858 people. But the latest and the last case of MERS was in 2017. The SARS COVID-2 or our present COVID-19 also started in bats, but we do not know what the intermediary is. It went on to the humans. We've lost 2.6 million lives and still counting. Next slide, please. Transmission from bats to intermediary onto human beings, from human beings onto other human beings. Next slide, please. Now, COVID-19 was declared by WHO as an international public health emergency on the 30th of January 2020 and a pandemic on the 11th of March 2020. Next slide, please. Epidemiology, how does it spread? From an infected person, it goes on to infect 5.7 others. And those 5.7, each of them will infect 5.7 others, and the cycle goes on. Now, virus primarily spreads through respiratory droplets, aerosols, and contaminated surfaces. Contaminated surfaces, anything the virus will land on when they cough or sneeze or talk, infected from the infected person. Viruses, when they land on these surfaces, such as plastic or stainless steel, they last on it for about 4 days. Now, on cardboard, it lasts for about 24 hours. And on copper, which is the least it survives on, is copper, which is, when it lands on copper, it lasts for about 4 hours. Next slide, please. How did it spread? Right. The spread from the initial epicenter in Wuhan, which I already talked to you about, this spread could have been contained if global travel bans would have been imposed immediately. The delay in travel bans would have immediately stopped this spread. This resulted in the virus getting out of Wuhan into all the countries in the world, majority of the countries. Other risk factors which played a part in viral spread were delay in social contacts restrictions and delay in restricting clustering and mass gatherings. Other factors which have contributed to the spread were urban centers and nursing homes and care homes. Next slide, please. How do we stop the spread? Slowing down and break the chain of the virus transmission. How do you do that? An infected person, identify him, isolate him, test him. Identify all the contacts that he has, track, trace, and quarantine these people and test them. Other components that will stop the spread of transmitting would be by physical distancing, at least 1 meter, frequent hand hygiene, respiratory etiquette, wearing a mask. Now, every country, if you look back when the virus started, Australia and New Zealand were the two countries where there were very strict quarantines for travelers put in place. That's why they had such few amount of cases and fewer deaths. Now, quarantining travelers should be the center of every national COVID-19 strategy. If we do not quarantine the travelers that are coming in, they're going to bring in variants, they're going to bring in other viruses. If they are not, they're going to spread it. Next slide, please. This is COVID-19. On the left-hand side slide, you'll see how it is trying to enter. It spikes, latches onto the ACE2 receptor, pierces the cell membrane, and in it goes on the right-hand side. You'll see this in a more, it's just a better slide showing the next one. You'll see how it enters. Next slide, please. There you are. There's the coronavirus on top. It's gone and it's latched on to the ACE2. The green you can see and pierces the membrane of the cell and in it goes. That's how it pierces and enters the cells. Next slide, please. COVID-19 symptoms. 3, early phase, pulmonary phase, and inflammatory phase. Early phase, stay at home. You get a fever, dry cough, fatigue, head and ache, headaches, pains, loss of taste, mild constitutional symptoms, and a loss of smell, maybe a GI symptoms, diarrhea, etc. You stay at home, you self-isolate, you take a test, tell all your contacts to isolate and take a test if positive. Stay at home. Now, if your condition gets worse whilst you're staying at home, you are unable to cope, you started to get shortness of breath, generally feeling unwell, and unable to do basic tasks such as answering the phone or getting a cup of tea for yourself or small or reading a book, etc., and you're having problems, don't forget, ring 999 or 111 and you go into hospital. The second phase, the pulmonary phase, you have already got shortness of breath, you're hypoxic, there's a lack of oxygen, you're in hospital. You're treated in hospital. Okay? The inflammatory phase is the most severe and dangerous phase. You are in hospital, and this phase, you're struggling to breathe, you got acute respiratory distress syndrome, multiple organs are involved, you go into shock, you have cardiac failure, you have stroke, you may have thromboembolic phenomena, etc., etc. And you may end up, if you're not already in the ICU, you'll end up in the ICU on a ventilator. Okay. Next slide, please. How do we diagnose COVID? Simple, a throat swab, PCR, or a nasal throat and nasal swab, which is called the polymerase chain reaction test, the PCR, and you take those tests and send it off, and within 48 hours, it's getting better now. It's within 24 to 48 hours. 48 hours, you're having the result. But before, people had to wait 4 or 5 days for the results to come in. You have the other tests, which are the antigen antibody tests, and more recently, the lateral flow test, which is also called the rapid test. The result is given out in 30 minutes. The government has rolled out to all the NHS and the frontline staff and care home staff, etc., where we have to have these tests taken twice in a week and report to our relevant. Okay. Now, what I have to tell you about is the lateral flow test is rather gives out more false negatives. Okay. These tests are all expensive, but irrespective of what test you have, please, 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 I beg of you, if you have any symptoms, sore throat, temperature, loss of smell, loss of taste, etc., and you've been in touch with anybody with COVID or those who have had COVID and been in touch, please take a test. They're easily available. In every town, every city, there are test centers there. You can walk in test centers or drive through test centers. All you go is you go online and you book your test in, and away you go. Next slide, please. Now, who are most at risk? Older people, comorbidities, cancer care patients, male sex. I'll come back to all these in a minute. Older care people, because their immune system is, because of age, does not work as 100% as a younger person's does, and they are more prone to catching illnesses. Comorbidities, yes, people with hypertension, chronic cardiac failure, COPD, asthma, chronic kidney disease, and above all, people who are obese, those whose BMI is above 40. And people who have got multiple comorbidities are more prone to catching COVID. Other people receiving cancer care. Now, in the slide, you'll see there's male sex. This has been put in because males have been known to, mortality has been 2.4 times more than females with severe COVID. The mortality rate in the male sex is higher, 2.4 times more than the females. Ethnicity, what can I say? Ethnicity, it's being investigated why they have it, but a word, and what researchers have come back and what we talk about now is that because ethnic people have got comorbidities and high BMI, etc., etc. I won't go into detail. I'm sure there are trials being done and you will learn about this in due course. Other factors, deprivation, socioeconomic factors such as poverty, poor and overcrowded housing, poor sanitation, poor public health, and healthcare system is responsible for this, such as some of the third world countries. Next slide, please. COVID in children and pregnant women. Children, when I wrote this slide, I'd written rarely causes severe illness. Now, things have changed since writing this slide. There are more children getting the variant form of COVID, and there are more children dying of severe COVID. Not as much as the older population, but the numbers are slightly increasing. But when the children, when they get it, they got mild symptoms, non-specific, cough, fever, GI symptoms, etc. Pregnant women, pregnancy increases rate of hospitalization and ICU care. And when a pregnant woman goes in, more than likely they'll end up with mechanical ventilation. But there have been very few deaths or no deaths. Now, pregnant women who have pre-existing maternal comorbidities are more at risk of catching COVID and ending up in ICU admission. Next slide, please. Treatment, very simple. Mild to moderate, 80 to 90% of COVID cases are mild to moderate. You stay at home, take paracetamol, ibuprofen, fluids, rest, and Bob's my uncle. Those who are severe, it was only about 10 to 20% you end up in hospital. You end up in hospital, nursing care is required, oxygen. Now I've put this monoclonal antibodies here. This is not a license for the UK, but monoclonal antibody is one of the treatment given in the United States of America, where this is only given to mild COVID patients. You've got mild case of COVID, you go into hospital. This is an IV infusion. It's given by IV infusion. You go in to the A&E and emergency unit, and they will inject you with this monoclonal antibodies through a drip. You take it, and once the drip is finished, all your stats are good, they send you home. Okay, but it's not yet licensed in the UK. Now the treatment in UK is the viral treatment, remdesivir and dexamethasone for inflammation, etc., which has been a godsend for when the patient is in the inflammatory process. Of course, there's the mechanical ventilators, etc., and all patients ending up in the ICU are about 10.9% of patients end up on the ventilation, mechanical ventilation. Next slide, please. I'm not going to talk about this. I had put this slide up before we had a speaker come who's going to talk more about this. Just please take a note of these, what is there, the sign symptom, because I'll be taking away your thunder. The next slide would be the same, so we're going to go to the next slide. This one, again, I'm sure the next speaker is going to talk about it, and we will move on. Next slide, please. Mutations and variants. What is mutation? Very simple. Mutation are changes in the genetic material. That is, the viral DNA changes. That is, the DNA code is changed. So that is called mutations. Now, what are variants? In simple language and people to understand, viruses that changes from its original. What it was from original has slightly changed, called a variant. It is common to see new variants of a virus over time. We see this all the time. It's not only limited to the COVID-19, but to all other viruses. Next slide, please. What do we know about variants? Viruses constantly change through mutation, like I've already said. New variants of a virus are expected to occur over time. Sometimes new variants emerge and disappear, and other times they emerge and persist. Okay? Multiple COVID-19 variants have been documented globally, but for the purpose of this talk, I'm only going to mention just a few. Next slide, please. Some known variants. UK or the Kent variant. This is spread into more than 50 countries globally. When I wrote this slide, it was 50 countries. It's gone more widely spread than 50 countries. The South African variant spread to more, it says here 20 countries, but it's getting more widely spread. It's over 25, 30 countries at this moment in time. Brazil variant is spreading fast, and it's quite a dangerous variant. The Californian variant, I'll come back to this one in a minute. Then we have the New York variant, we have the Japanese variant, and there are other variants in the world which I am not going to mention, which are of not a lot significant until they become very severe. Coming back to the Californian variant, the Californian variant, when it was first recognized, it was the UK variant. And this has gone further changes and further mutated and has become more transmissible and more severe in the disease part of it. So that is the Californian variant. Next slide, please. What are the consequences of these variants? You know, people may think, oh, we're talking about variants. Yes, what is so important about it? The importance about variant is 4. Number 1 is easy transmission. Number 2, they escape diagnosis. Number 3, escape treatment. Number 4, they escape immunity. Okay, escape transmission, ability to spread more quickly in people. Now, the UK variant has the clinical, there have been some trials done and some data have come in, is 55% more transmissible than the ordinary COVID-19. Escape diagnosis, ability to evade detection by specific viral diagnostic tests. You take a test, PCR test, etc. If there's a variant which the test will not be able to recognize, it will escape diagnosis. Now, escape treatment, the third one, which I said, decreased susceptibility to therapeutic agents. I did talk about monoclonal antibodies in the previous slide, and that is where this thing comes in. If there is a variant, which we do not know, if the monoclonal antibodies will act or can act as therapeutic agents to curtail the virus from multiplying. Okay, so that is escaping treatment. Now, last, escaping immunity. Now, how does that happen? It is ability to evade natural meaning you have caught the virus, you got infected and you got natural immunity yourself. Okay, and vaccine-induced immunity, vaccine-induced by injection. So what the virus will do, the variant will do, it has the ability to smartly evade your natural immunity and the vaccine-induced immunity, and what result is vaccine failure. And that's why variants are so very important. Okay, next slide, please. Now, this is just a slide for you to see. It says new UK variant. This was a slide taken a long time ago when the variant had just come in, the UK variant. So please forgive the new. It is spread to more than 50 countries. It's a thriving and well-documented variant now. This is how it looks under electronic microscope. Okay, next, please. This is South African variant, the B1351. Next slide, please. This is the Brazilian variant, the P1 it's called. Okay, I'm afraid I haven't got a slides for the Californian variant, the New York variant, and the Japanese variant yet. I'm yet to find them. Next slide, please. Right, I'm going to talk a little bit about vaccine development, the different ways in which vaccines are developed. From time immemorial, from a long time, vaccines have been developed. We have had the polio vaccine, we have had the typhoid vaccine, we've got the measles vaccine, and we've had the MMR vaccine, etc. The list goes. Now, they are listed here for ways of which vaccines are developed. Now, the first is the inactivated or weakened virus vaccine, which use a form of virus that has been inactivated or weakened, so it doesn't cause disease, but still generates an immune response. Now, the protein-based vaccine, which use harmless fragments of protein or protein shells, which mimic the COVID-19 virus to safely generate an immune response. Now, the second, the third, and the fourth are very important ones. The viral vector vaccines, which is the AstraZeneca and the Johnson & Johnson vaccine, which use a virus that has been genetically engineered so that it can cause disease, but produces coronavirus protein to safely generate an immune response. Now, AstraZeneca has used the chimpanzees as the adenovirus of chimpanzee to genetically engineer it in order for it to produce protein which will mimic the coronavirus protein and create an immune response. That's how they've done it. Now, the RNA and DNA vaccines, this is the Pfizer and Moderna. This is the creme de la creme. It is the cutting edge technology that uses genetically engineered RNA or DNA. In case of Pfizer and Moderna, this is the RNA, mRNA they use to generate a protein that itself will safely promote an immune response. Okay. Next slide, please. COVID-19 vaccines that have been approved are in development. Worldwide, there are 15 different vaccine are pretty. I'm not going to talk any more about the other vaccines. I was reading some papers day before yesterday. There are apparently 300 vaccines globally being developed. They're all, most of them are in phase 1, phase 2 trials, very few in phase 3 trials. For the purpose of this talk, I'm just going to talk about the Pfizer and the Moderna and the AstraZeneca vaccine, because they are the 3 vaccines that are now being given in the UK. The Pfizer and Moderna are the mRNA-based vaccine. They are developed that way. The AstraZeneca is the non-replicating viral vector vaccine. Okay, how these vaccines work to the lay person. This is very lay medically way of explaining. The vaccine teaches the body immune system to safely recognize and block the virus that causes COVID-19. Okay, the next slide will show you how the vaccine works. How do these vaccines work? You inject the vaccine will help build body's natural defenses and body protection. And how do they do it? Vaccines have produced antibodies to fight the disease, thus helping build the immune system. Once the immune system has been built and the antibodies there, the body remembers the disease and how to fight it. And when you're infected, the immune system responds by recognizing the invading germ and kills it. And that's how it works. Next slide, please. This slide speaks mountains. Look at it. Vaccine-generated antibody on the left in action against the COVID-19. What a punch. Next slide, please. Who should and who should not have the COVID-19 vaccine? Simple. Who should? All between the ages of 18 and over in the UK, let me clarify, the UK can have the vaccination. But I must say clinical trials are in progress for children vaccine. And Johnson & Johnson are producing, they are in phase 1 trial to have a vaccine for children from 12 years and above. And this vaccine will be ready for vaccination and approval by the end of the year. Who should not have a vaccine? Certain medical conditions, such as who are receiving chemotherapy, life-threatening allergies to vaccine ingredients, or those who are on immunosuppressive treatment, or pregnant women. I'll come back to the chemotherapy and immunosuppressive in a minute, which is, if you are receiving chemotherapy or immunosuppressive treatment, please speak to your oncologist or your rheumatologist, who will be able to guide you if you need the vaccine. And if you do need the vaccine, they'll recommend a particular vaccine to have. If that be the case, you must have the vaccine. Okay. Now, pregnant women. Pregnant women is listed here, but pregnant women, the Royal College of Obstetricians have come out with it, that pregnant women who have comorbidities and are pregnant and must consult their obstetrician and seek advice and get vaccinated if the obstetrician advises them to do, and the obstetrician will be able to tell them which vaccine they can have. All right? Okay, vaccination must be postponed. Vaccination, you had an appointment, etc., and you're waiting to go, and you become severely ill, you have high temperature, you cannot have the vaccine. You had a positive COVID test 28 days before, you cannot have the vaccine. If you have developed any symptoms of COVID-19, you cannot have the vaccine. If you've had other vaccinations, such as any vaccination, Hep B, Hep A, or you had the shingles vaccine or anything like that, with the last 7 days, you cannot have the vaccine. And if you've been self-isolating, you cannot have, or the last 7 days, you cannot. And above all, I've had an anaphylactic reaction or shock to the constituents of a vaccine, or if you've had similar shock if you had a vaccine before. Okay, let's move on. Next slide, please. Yes, okay. What is in the vaccine? Vaccines, antigen, adjuvant, preservative, and a stabilizer. That's it. Now, Why an antigen? The antigen helps develop the antibodies. Why an adjuvant? Helps boost the immune response. Why a preservative? Ensures vaccine stays effective, and a stabilizer protects the vaccine during storage and transportation. Now, both Pfizer, Moderna, and AstraZeneca vaccine do not have any preservative, okay? Nor do they have any animal tissue or animal extracts, so that any religious beliefs or people with religious beliefs such as Hindus, Muslims, Jews, Sikhs, Christians, or any religious denomination, if you have any religious inhibition to have the vaccine, which you think is in there, please, there's nothing in it. The vaccines are kosher. Please, when you get the invite, do take it. And there is nothing in the vaccine religious-wise to prevent you from having. Okay? Next slide, please. Side effects of COVID-19 vaccination. Simple, mild, and serious. I'm going to add something else to it by the end of the slide because things have developed since writing the slide. Side effects after vaccination: a sore arm, injection site, a bit redness there. You feel tired, a little headache. You may feel achy. You may feel a bit nauseous. You may be sick as well. Just take paracetamol, plenty of fluids, and rest. That's your treatment. The side effects, most serious side effects, are the anaphylactic reaction. Sure. You would have been asked before whether you had any allergies to any ingredients of the vaccine. And if you said no, and you had an anaphylactic reaction or reaction, very few people have it, 2.4%. Okay? Now, at every center, there are doctors and there are paramedics very well trained in dealing with anaphylaxis. Now, very simple. You have the symptoms of anaphylaxis, they will come in, get you, there's a room, they'll take you there, there's oxygen there, they will give you an epinephrine or adrenaline, it's said here, in America it's epinephrine, and oxygen. If you need it, you may get an antihistamine or a cortisone injection, and if you're short of breath, some beta agonist to help you. Now, there have been very few cases, like I said, 2.4%, and all these cases, when treated at the center, they go home in a couple of hours when they've settled 2 to 3 hours. Only very few people have been sent to an A&E for them to be observed through the day. And what the records and the paperwork that I have seen and read, there's been 1 case per 100,000 who have been kept overnight after anaphylactic reaction in hospital. Okay? So, side effects. Now, the other side effects of the vaccination, which is getting more and more prevalent now, is some people are persisting to have some headaches, some lethargy, post-vaccination syndrome. Okay? Now, this will last, and fatigue, a little bit of tiredness, that will continue for more than 3 or 4 days, maybe longer. Don't forget, if it's over 4 days, consult your GP, because there are a lot of thromboembolic phenomena, not a lot of, very few, but bear that in mind. You must see your GP to exclude, get checked out. So majority of them, 99.9% will settle within a matter of days. Okay, we move to the next slide, please. How effective is COVID-19 vaccine? Good protection when you have 1 dose, much improved protection when you have the 2nd dose. But it doesn't finish there. You had the 1st dose and 2nd dose. It doesn't finish there. Don't think that you're not going to be infected again, because you will get infected again, because vaccines are only between 90 and 95% safe. And 5% you may catch COVID again. So please continue to wear the mask, hand hygiene, and social distance. And you need to do that because Or there are others like children and very ill people who are unable to have the vaccine in order to protect them from transmitting. And that's the reason. Okay. Next slide, please. In this slide, you'll see I collected this from the BBC website. AstraZeneca is, you see, it's the viral vector vaccine, and you see in the fourth column how effective at one dose, 70% effective, whereas the Pfizer is 90% effective after the first dose. Now, a second dose is necessary for both these vaccines to provide longer-term immunity. Longer-term immunity is very important. And we do not know how long these longer-term immunity will last. Trials have to be done, and time will only tell how long each vaccine is, complete vaccination will last. Next slide, please. Is COVID-19 vaccine safe? Yes. Remember, you are far more likely to be seriously injured by a vaccine-preventable disease than by getting vaccinated. Even death with COVID-19. Now, the risk of being struck with lightning is higher than having COVID-19 vaccination, or being involved in a car accident and dying from it than having COVID-19 vaccination. The benefits of vaccination greatly outweigh the risks. Next slide, please. Why do we need the vaccine? Number one, to protect yourself. And number two, those around you who are unable to have the vaccine because of either illnesses or something they have that they are prohibited from having the vaccine, and children or seriously ill people. Next slide, please. Now, vaccinations in arms as at 30th of March, this slide has changed dramatically since then. So I'll first go through this and I'll give you the figures in a little while. United Kingdom, 30.68 million first dose, and second dose, 3.83. In England, 23.7 million and 1.6 million second dose. In Wales, 1.4 million and 424,000 the second. Now, what I'm going to say is these figures have been overridden by, now the total in UK have been 37 million doses have been given. One single dose is 31.58 and second dose is 5.43 million. So that's making a 37 million doses about 5 days ago. Next, please. Why wear a mask? Keep my distance. Why wash my hands? Patients keep coming to me, asking me they're fed up of lockdown, fed up of being told what to do. Why should I wear a mask? Why should I keep my distance? Why should I wear? Right. Simple reason. Those of you who are reading, I'll give you show you exactly why. I hope this will make sense. Next slide, please. Why wear a mask? The difference between droplet and airborne transmission. You can see the droplet transmission. This person is coughing and sneezing, and you can see her droplets of saliva and mucus spreading, coming out of her mouth. They are only 5 microns in diameter. And do you know how thick is your hair? 60 to 120 microns wide. Whereas those droplets that are coming out of her mouth are 5 microns. And the mist that you see further up, the green mist, that are just mist and just mixed with air and is suspended, and anybody walking through it will catch the virus. And that's why we say, please wear a mask so that you will not cough, or when you talk, etc., you won't be spreading your coronavirus to others. That's the reason. Next slide, please. Why the distance? This is a high-speed video imaging showing the trajectories of a sneeze. The yellow is a person who's just sneezed. You can see the trajectories of the droplets of saliva and mucus coming out of his mouth and nose and going in green all the way up to 6 feet away. And you see the mist, the yellow and orange mist that you see around there is the mist mixed with the air, spreading up to about, it's seen to go as far as 27 feet. That is why the distancing. I hope that makes sense. Next slide, please. Now, why wash hands? Soap has hybrid molecules. These hybrid molecules have got a head and a tail. The head is hydrophilic and the tail is hydrophobic. Hydrophilic loves water. Hydrophilic hates water. The tail hates water. So when you wash your hands, rub soap into it, and water touches it. Now, as soon as the water touches it, the tail tries to run away from the water and wedges into the lipid virus capsule and prizes it open. Tails are attracted to lipids and to oils. It prizes it open and destroys the virus. So that is why wash your hands for 20 seconds thoroughly. 20 seconds, that's important. Okay, and that's why we preach. Keep your distance, wear your mask, wash your hands. Next slide, please. Herd immunity. What's herd immunity? It's also called the population immunity. Okay, now you can gain herd immunity by actually catching the infection, and secondly, by having an injection or vaccination. Okay, but the WHO very wisely recommended that for this coronavirus, we should come out with, we should have herd immunity by vaccination. Why? Because there'll be less disease, less severe disease, and fewer deaths. And that is why. Next slide, please. Really coming to an end very quickly. Why about COVID-19 rumors and misinformation and disinformation? Right. Next slide, please. Vitamins and minerals supplement will cure COVID-19. Fact, vitamins and minerals supplements cannot cure COVID-19 vaccinate. Hydroxychloroquine stops one from catching COVID-19. Fact, studies show that hydroxychloroquine does not have clinical benefit in treating COVID-19. It is used for malaria and other autoimmune diseases. It should be administered under medical supervision and by a clinician. It has a lot of toxic. Next, bleach will protect me from COVID-19 as advocated by Trump. Spraying and introducing bleach into your body will not protect you from COVID-19 and can only be dangerous. Next slide, please. Vaccines alter my DNA. Fact, vaccines do not alter the DNA. Okay. Vaccines contain a microchip. COVID-19 do not contain microchip. They are made up of either protein material or viral vector. Vaccine contain human fetal tissue. Fact, COVID-19 vaccine does not contain human fetal tissue, nor does it contain any animal tissues or extracts, like I said before, for religious beliefs people. Okay, next please. Wearing masks deprives the body from oxygen. Fact, the prolonged use of medical masks when properly worn does not cause CO2 intoxication nor oxygen deficiency. Young people, teenagers are saying that they cannot catch COVID-19. Fact, people of all ages can be infected by COVID-19 virus. All facts and figures are there now. Younger people are getting infected. Younger teenagers are getting infected. With the variants about, there are more and more younger people getting infected. So be warned, it's not a fact. Fact is everybody can be infected by COVID-19 virus. Taking antibiotics will prevent COVID-19. Fact, antibiotics cannot prevent or treat COVID-19. Antibiotics work only against bacteria, not viruses. Now, next slide, please. How to stop fake news? Does the story sound believable? Ask yourself. Has the story being reported elsewhere in the BBC, NHS, public health website, etc.? Or ask someone you trust. What do they think? Ask a doctor, ask your pharmacist, ask any scientist who you may know, or somebody who's got a little brains and who can think. Ask them. If in doubt, do not, I say, do not share this information. Next slide, please. Trust what you have heard so far has been helpful. There's much more to learn. Next slide, please. Thank you. Thank you very much. I trust you enjoyed that. It is a bit tiring, but there we are. We got some very good speakers here who are going to take you through there. Now, it is indeed my privilege and pleasure to introduce, for your acceptance, Dr. Husni Habush. He's a fellow of the Royal College of Physicians, a fellow of the Royal College of Pathologists. He's a consultant hematologist and an assistant professor. He is recognized nationally for his bone marrow and peripheral stem cell harvest programs. He's an examiner both nationally and internationally for the Royal College of Physicians in London. He's a leading consultant hematologist at Spires Hospitals. There is so much more I can say about Dr. Habush's work, his experience and his commitment as a medic. And in short, we are privileged to have him with us to hear him talk about the effects of virus on our blood and our cardiovascular system, those who have been infected with COVID. Over to you, Dr. Habush.
Thank you very much, Akram. Good evening, ladies and gentlemen. Hematology, as Akram said, is the science of blood diseases, and hematologists have been heavily involved in the management of the pandemic. This, next slide, please. This is due, next slide, please. This is due to the fact that the manifestations of the disease itself are reflected in the blood and cause blood changes. Hematologists are also involved in the treatment, especially in the treatment of thrombosis. Furthermore, the changes that occur in the blood do have a prognostic implication, i.e., they do help us to have an idea about the outlook of the disease. And fourthly, hematologists are involved in the follow-up of patients, especially those with thrombosis. Next slide, please. To understand the impact of COVID on the blood, let me take you a step back and explain how blood is made. Basically, the bone marrow is the factory that produces blood. It produces an ancestral cell, we call it the stem cell, and this differentiates into white blood cells there are different types of these. These are designated to fight infections. We have the red cells, which carry oxygen through the system, and we have the platelets that prevent bleeding and also take part or share in the process of thrombosis or clotting. Next slide, please. So the COVID virus affects the white cells. Usually it causes a reduction in the production of red cells. Less frequently, and much less frequently, there is an increased number of white cells, and the percentage of this complication, the white cell involvement, is about 50 to 60% of the cases. It also impairs the production of red cells, leading to anemia with low hemoglobin, and this reduces the oxygen delivery to the organs. It impairs the production of platelets, or it changes their function, and this can lead either to thrombosis or bleeding. There's also an important consequence of the viral infection, and that is it stimulates the body to secrete some biochemical substances, or what we call inflammatory markers, which normally are secreted with every infection, be it viral or bacterial. But with the COVID, the production of these, pardon me, cytokines is so enormous that it causes a cytokine storm, leading to both metabolic changes in the body as well as problems within the bone marrow itself. Finally, the virus does affect the clotting mechanism, and it does also affect the thrombosis that has been recently recognized as a possible complication of the AstraZeneca vaccine. Next slide, please. How does the virus affect all these changes or conduct this damage? It's usually by direct damage to the bone marrow components, affecting the cell, causing cell death. The second mechanism is that in every cell in the body, there is a finite lifespan after which the cell is programmed to die. Now, this usually takes a certain length of time. With the cytokines, with the cytokine storm, this normal cell death, which we call apoptosis, is accelerated and cells die prematurely. The third mechanism is that the virus alters the immune system in the body. Now, the immune system is a vigilant system in the body that guards against foreign intervention. When it is altered, it gets fogged, and it fails to recognize the normal components as being self-components, and produces antibodies, we call them autoantibodies, and these destroy the cells. Next slide, please. Now, let me take you to one of the very time-honored principles in medicine, which is called Burkhoff Triad. Now, Burkhoff Triad states that for every thrombosis, we need three components: stasis of the venous circulation, as occurs in mobility; hypercoagulability, that is an increase in the tendency of the blood to clot or congeal; and endothelial damage. Now, endothelial cells are the lining cells of the blood vessels, and when they are damaged, this predisposes the patient to thrombosis. If I can take you to the left side, the first diagram, which is designated normal, it shows that the blood cells flow normally and evenly through the blood vessels. However, if you look at number one diagram, you find that there is a clot has happened on the side of the blood vessel. These clots usually grow in size as depicted in figure 2, and then eventually a portion of these clots detaches from the mother clot and travels up to the circulation, usually into the lung, causing pulmonary embolism or clots in the lung. The picture on the right shows you what happens when the thrombosis occurs in the leg. Usually the leg is swollen, the right one is swollen, it's red, it's tender, and this can cause even further complications which are beyond the scope of this lecture. Can I have the next slide, please? So why thrombosis occurs? Usually, as I said, the virus causes damage to the cellular lining of the blood vessels. Patients stay in hospital, ITU, so they are immobile, they're bedridden, and that fulfills the stasis component. Usually, we have natural substances in our body that guard us against thrombosis and keep the fluidity, the blood fluid and these components can be also damaged by the virus. The virus, as I said, can cause alteration in the immune mechanism, and this in turn causes changes in the clotting process, enhancing the clotting process. And finally, hypoxia, which is reduced oxygen level in the blood, causes thickness of blood, hypercoagulability. So all these mechanisms more or less fulfill the Burkhoff Triad, and thrombosis, when it occurs in the context of the COVID infection, not the virus, not the vaccine, usually is associated with a poor outcome. Next slide, please. The thrombosis is usually on the venous side. It can occur between 15 and 60% of the cases. It is predominantly in the lungs, and usually it's microscopical. It was not identified in the initial periods of the pandemic, but now it is well recognized. It can, to a lesser extent, it can involve the arterial part of the circulation and can cause either strokes, or if it involves the coronary arteries, it can cause heart attacks. Can I have next slide, please? To understand what we mean by clots in the lung, this is a diagrammatic presentation of the lung. The lung is made of small sacs grouped together like bunch of grapes. And around these sacs, there are arteries and veins. And inside the sac, there occurs the gases exchange between oxygen delivery to the body and delivery of carbon dioxide out of the body through the lung into the atmosphere. Now imagine that these blood vessels are blocked by clotting, so the oxygen exchange does not take place. Can I have next slide? What happens then? So there will be a reduced oxygen passage from the lungs to the blood. In turn, this causes reduced oxygen delivery to the tissues, and the organ fails to function. If it occurs on the arterial side, that leads to interruption of blood supply to the organs and ultimately death. Next slide, please. In blood diseases or in hematology, there's always a guiding principle when dealing with thrombosis is to observe what we call hemostasis. Hemostasis is a balance between the tendency of the blood to clot and the others, on the other side, the risk of bleeding. And when dealing with thrombosis or treating thrombosis with blood thinners, we have always to observe this fine balance, making the blood thin enough not to clot, but thick enough not to bleed. And this requires a fair degree of expertise, I think so. Can I have next slide, please? So how do we treat thrombosis? Usually, the first and most important thing is to treat the infection and maintain organ function. We usually correct the emerging metabolic consequences or complications, and then we use blood thinners. We have an array of blood thinners. Nowadays, obviously, we use a special type of heparin, and that is used during the illness itself, usually the severe illness, and then the patient continues to use some form of blood thinners after discharge. And it is in this period that we have, again, to maintain that vigilance, observing a fine balance between the bleeding risk and the thrombosis risk in order to avoid any failure of thrombosis and recurrence of the clotting mechanism. Next slide, please. I think I've briefed you enough about the role of hematologists and hematological complications, and thank you for your attention.
Thank you. Thank you, Husni. Very informative, and I'm sure people would appreciate what you've said. Time is getting short, so I'm going to move on to our next speaker. People have been waiting to hear. Dr. Benita Kane, a fellow of the Royal College of Physicians, is a consultant respiratory physician at Manchester University Foundation Trust. She has an interest in airways disease, quality improvement, and leadership. She's currently the lead for integrated respiratory care at MFT, the Greater Manchester Respiratory Health Innovation Program, and the Northwest Severe Asthma Network. She has recently been appointed as an Associate Medical Director of the Manchester Local Care Organization. During the pandemic, she has led the cross-system Manchester COVID virtual ward, as well as co-author Rising British Thoracic Society Guidance for Community Teams. She is a member of the Long COVID Strategy Group in Greater Manchester and currently working with the NHS Chief People Officer as a member of the NHS BAME Clinical Advisory Group, advising NHSE on strategic issues and feeding back on what is required in relation to the disproportionate impact on COVID-19 on BAME staff. She's involved in a number of national respiratory programs, including the Royal College of Physicians QI faculty, the RCP National Asthma and COPD Audit, Program Board, and Asthma Advisory Group, and the NHSC Long-Term Plan Delivery Workstream, and etc., 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 etc. I have got another page that I could have read about her, but ladies and gentlemen, Dr. Benita King.
Thank you, Akram. That's a very kind introduction. And I'm really delighted to be here to talk to you this evening. And I'm going to speak to you about the lasting impact of COVID-19, both from some of my own personal experiences, but also of those of my colleagues around me. If I could have the first slide, please. So COVID-19 has really given us the biggest challenge in this country since the Second World War. And it has been 12 months of, heartache, devastating loss, such great difficulty for everybody, for those who've been isolating, to those who've lost loved ones. But at the same time, I think it has also been a time of incredible development of science. I mean, just the development of those vaccines in such a short space of time, people coming together, systems coming together, and the NHS doing what would have been seen as unthinkable 18 months ago. We have looked after, between us in the NHS, over 455,000 people in hospital with COVID-19 and over 30,000 intensive care admissions. And we have to remember that this is capacity we didn't have, and this is on top of still providing other urgent care throughout the year. And of course, other parts of the NHS have suffered enormously. So that in the middle photograph there is me and some of my colleagues in the Northwest Lung Centre. But I've been part of a massive team that has just done an incredible job over the last 12 months, all the way from the critical care to the care we've delivered in the community, monitoring people with oxygen probes. And whilst many of those people have sadly died, the great majority of them actually have recovered and have gone home, but we do know that many of them are being left with longer term problems. Next slide, please. I couldn't do this talk without mentioning some of the people we've lost along the way. This is an incredible artwork that was done using the faces of all the healthcare professionals who've died during COVID-19. I just think it's one of the most powerful images that I've seen in a very long time. Next, we have to remember that behind every one of those pictures is a person with a name and a family and colleagues and a department that's desperately missing them, from young nurses who've got their entire careers ahead of them to people like Professor Tony Gershlik, Professor Donald O'Donoghue, who leave this incredible legacy behind them, pioneers in their fields that we just can't fill their shoes, and you know, consultants who you can't just replace like that. So, you know, moving forward, we've lost so many of these staff. It's leaving a huge gap for us. And then we have another big problem in the NHS, and of course in the public as well, and that is the problem of long COVID. Next slide. So what is long COVID? There are a few different definitions floating around, and I like this one. It talks about, as a definition, this is someone who's not recovering for several weeks or months following the start of symptoms that are suggestive of COVID-19, whether you were tested or not. Now, I like that description because right at the start of the pandemic, a lot of people in the community weren't testing, but have been left with these long-term symptoms that they're now trying to make sense of. And we shouldn't exclude those people from being diagnosed with long COVID. The World Health Organization estimates that this can impact on 1 in 10 infected people. So that's a huge burden of people who are now sick in the longer term. This image has been developed by a doctor who is part of a big group of healthcare professionals that's got thousands of people on it now on Facebook. It's called the Long COVID Doctors Group, I think. And they have been collecting data from each other, really. And what is evident is long COVID can affect any system in the whole body. The common symptoms are highlighted in the blue. So starting from the brain, having what we call brain fog, that's kind of poor memory, confusion, difficulty paying attention or doing tasks that you didn't have difficulty with before. Chest pain, palpitations, very common, shortness of breath, fatigue, changes in taste and smell, not just loss of taste and smell, but people are complaining of like burning smells, very, very funny tastes, and so on and so forth. It can really affect any part of the body. Next slide. This is just some data to show what are the most common symptoms are. So the graph on the left, and by far and away, fatigue, like terrible fatigue and shortness of breath are the most common symptoms, followed by joint pain, chest pain, cough and loss of smell, and then you get more rare symptoms below that. Research is starting to emerge. Leicester have done a fantastic study. They've spearheaded it. They've already assessed over 1,000 people. Now, these are the people who are sickest, had been in hospital, and they've looked at them 4 to 6 months later. And just to note that over a quarter of the people in this study were ventilated, so they were sick enough to be in intensive care on a breathing machine. And of those people, only 29% felt fully recovered by the 6-month mark. 1 in 5 reported a new disability. A whopping 19% had to change something related to their work as a result. And the worst hit people appeared to be women who are middle-aged, white in ethnicity, interestingly, as opposed to those who've died, and having more than 2 comorbidities, so things like diabetes and heart disease. So what we're starting to see here is a picture where we're going to have thousands and thousands of people across the country who are disabled by these symptoms. Next slide. This slide was put together by one of my colleagues who sadly is suffering from long COVID. She's a consultant herself, and she has described the personal impact, both in terms of emotionally, the guilt, the frustration of not being able to work, the embarrassment of being off sick as a doctor, that sort of reduced self-worth, and then of course the impact of having reduced function due to the fact she's got pain and she's very fatigued. She can't interact with her kids as well as she could. She worries about work and being able to look after her patients. And of course, she's one of, she's a breadwinner in the family, and how is this impacting on her financially? And, this isn't unique to doctors, of course. This is up and down the country. There are people impacted in this way. Next slide. Long COVID in children. Now, this is an area that we are learning about. There is very little in the published data about long COVID in children, and actually most of the information I've got for this talk has been from this fantastic group that's been set up online called Long COVID Kids by volunteers, and it's spearheaded by a lady who's a rehab physio but has had COVID herself, and her children have. The last data from the Office of National Statistics suggests there's nearly 80,000 kids suffering with long COVID, and around 5,000 of those have been in hospital. Next slide. In children, again, it can affect any part of the body. So the top 10 symptoms are chest pain, headaches, again, fatigue is very common, joint pain, sore throats, rashes, dizziness, changes in mood, and then gastro symptoms as well. And next slide. What we're seeing is that these are children who were perfectly fit and well and happy prior to having COVID. And you can see by these signs they're holding up that some of them are really in the long haul. Day 212, day 101, day 349, their lives completely turned upside down. And unfortunately, the experiences that these children and their parents, and actually a lot of adults with long COVID are having, is very negative. Finding that their concerns are being dismissed, being told it doesn't exist in children. Quite often they'll have a barrage of tests which come back as normal, and therefore they're told, well, there's no problem, or perhaps it's in their head, or the child is anxious. So there's huge numbers of people who are out there not feeling heard, not feeling supported. These are kids that now have had to go back to school, very fatigued, struggling with lessons, it's affecting their schoolwork, struggling with PE and games, and actually there's this real sense of, as parents, we just don't know what to do, and a lack of advice. And that's compounded by the fact that there isn't a cohesive approach to research and data collection yet, as there is in adults. Next slide. So what is the NHS doing about this? Well, there is some good news, fortunately, and that is this has been recognised now by the government, and there has been some central funding allocated for long COVID clinics, both in adults and children. There will be a service wherever you are in the UK that has been set up or is in the process of being set up. And there is research ongoing, and things will get better as we learn. The other positive news is that people, even though it's taking a very long time, what we're finding is actually more people than not are improving with time alone and with support. And what's really interesting is there are some patients who are reporting improvements in their long COVID symptoms after vaccination. That's in and around 30% as a figure that I've seen and heard, but that's not official yet, as we need more data. However, it's not all good news. Unfortunately, there isn't enough resource for the scale of the problem. For example, in Greater Manchester, we've got a population of 2.7 million, and actually there's only going to be 3 long COVID hubs for that number of people. A lot of them are in the early stages of establishment, and when you look at the multi-system nature of long COVID, it's an absolute logistical nightmare to set these services up, because you need cardiology and neurology and rheumatology, and we have been set up as individual specialties for so many years that actually when we all have to come together to work on one thing, it's really difficult. There's still a lot of poor awareness amongst healthcare professionals. It's a new disease. We are still learning. We are struggling. We don't know what to do when the tests come back normal. But as we move on, things will change. We don't have very many treatments, but there are some things that can be treated. And so we clearly just have a long way to go. Next slide. So my final slide is really about what you can do if you or your child is suffering from long COVID symptoms. So I think importantly, you must be heard. So don't let people fob you off and say it's not real and your symptoms aren't real. Sometimes it takes persistence and finding the right person to listen to your story, and that shouldn't be on you as the public, but at the moment, unfortunately, that's the way things are going to be for a while. If there are symptoms like chest pain or palpitations or breathlessness, it is important to have investigations to rule out other problems. I really worry that people are putting things down to long COVID that could be other serious issues, and there is a panel that we expect GPs to do as a basic to rule out other things before referring on to long COVID services. Join a support group. I cannot emphasize how important it has been for people to be able to link with others who understand what they're going through. Top tip for fatigue is many people who are affected by long COVID were fit and well beforehand, perhaps had never been this sick in their life, and just don't know how to deal with the fatigue and just try and push through it. It's not the right approach. Fatigue has to be managed. There is a whole way of dealing with fatigue that we call paced recovery, and pushing through it is the worst thing that people can do, because then they have relapses where, you know, they get a bit of energy, overdo it, and then absolutely relapse for several weeks afterwards. Ensure that you're referred to a specialist service. You have to be persistent. It might be that you have to ask around in the support group to work out who the right person is. At some point in the next few months, hopefully we will have directories of these services, but at the moment it is tricky to find out where to be referred to. We've had a lot of discussion about vaccines already. My advice is get vaccinated. You do not want, having treated so many people with COVID and now long COVID, you do not want COVID. The risks of a vaccine are tiny. Just get your vaccine if it's offered. I couldn't recommend that more. Kids, there are trials ongoing in kids, but they're not being offered vaccines yet. And finally, there is a website called yourcovidrecovery.nhs.uk. That's free for anybody. And there's lots of really great advice on there. It's been developed by healthcare professionals. So next slide, I think that was all I was going to say. And thank you for listening. Happy to take some questions later or in the chat.
Thank you, Benita. That was very informative, particularly so in the light of so many patients that we as general practitioners are seeing with long COVID. And initially, when this was highlighted to us, doctors were dismissing their symptoms. It's more and more apparent that long COVID is a condition, and we are gratified that the central government and the devolved governments have invested into setting up clinics up locally, etc. And in my area too, there is a clinic set up, and we have been encouraged to recognize and refer patients to them. And thank you for all what you've said and what you do. And I'm going to now move on to another speaker, which is Miss Natasha Taladi. Miss Natasha Taladi is a clinical pharmacist working in intensive care unit in London. She has previously worked in specialist roles in cardiology, nephrology, transplant medicine over the last decade in the NHS. She also has international experience as a pharmacist and worked in 2 top teaching hospitals in Toronto, providing care advice to patients on complex immunosuppressive medications, etc., etc., etc. She's a high flyer pharmacist. Ladies and gentlemen, you better watch her. She is going to talk about medications and COVID now. Over to you, Natasha.
Thank you, Dr. Baig. Hello, everyone. I'm delighted to be here today. As Dr. Baig mentioned, over the last few months, I've been working in the intensive care unit in Royal London Hospital, which has been the largest single-site ICU in the whole of the UK during the pandemic. So this has been particularly challenging. So I just want to spend some time talking about COVID vaccines and other medications so you can make the right decisions about receiving the vaccines. Next slide, please. So, sorry, can we go back? Yeah, we're on the right slide. So if you're taking other medications, for example, medications used for high blood pressure, such as ACE inhibitors, Ramiprazole is one of the examples, beta blockers, diuretics or water tablets such as furosemide, or medications for asthma, diabetes, depression or epilepsy. And this is not a complete list of medications that the vaccine is safe to take with. These are just some examples. There have been no drug interaction studies done, but we know that due to the way the vaccines work, it will not interfere with good control of your long-term medications or long-term conditions. Next slide, please. Is the vaccine safe for people with heart and circulatory conditions? So yes, no vaccine will be approved unless it is considered safe for people with long-term conditions, including heart and circulatory conditions and older people. Pfizer, BioNTech, Oxford, AstraZeneca, and Moderna vaccine trials all included people with long-term conditions such as asthma, heart disease, liver and lung disease, diabetes, and high blood pressure. And as part of the clinical trials, researchers looked at whether there were any differences in how well the vaccine works in people with health conditions versus those without. And they found that the vaccine works just as well in both groups. So it is safe and effective in people with long-term medical conditions. Next slide, please. So I just want to spend some time talking about COVID vaccines and immunosuppressive medications. I think we've had some questions in the chat as well. So if you are on any immunosuppressive chemotherapy or immunosuppressive medication following an organ transplant or steroids, these are just some examples. This is an extremely vulnerable group of patients, and so they should not be excluded from getting the vaccine. It's safe to take in majority of the cases, but it may result in suboptimal response. We think that some response is better than none at all. And there are ongoing trials in these groups of patients, and we will get more information as we go along. So at the moment, the guidance is that if you're offered the vaccine, you should take it. And also you could, if you're concerned, you can always discuss with your specialist doctor if you have any further questions. Next slide, please. Is the vaccine safe for people taking blood thinners like warfarin or other anticoagulants or antiplatelets? So some examples of such medications are apixaban, warfarin, aspirin, and clopidogrel. Generally, yes, but you should let the person giving you the vaccine know that you're taking an anticoagulant. Like most vaccines, the COVID vaccine is injected into the muscle of your upper arm. So injections into the muscle may cause more bruising if you're taking a blood thinner, or may bleed a little bit longer than usual. This is not a cause for concern, and it shouldn't be the reason for not taking the vaccine. People taking blood thinners are often told that if they cut themselves, they may bleed a little bit longer than those who are not taking any blood thinners. So when you have the vaccine, if you experience any bleeding at the injection site, it may just take a little bit longer to stop, and you may get some more bruising. It's also important to make sure that your anticoagulant treatment is stable. So this generally means that you've been taking the same dose for a while, and that if you're on warfarin, that your INR checks are up to date and your latest INR level was in the right range. Next slide, please. So blood clots and COVID vaccines, I'm sure that many of you have read and heard about a possible link between COVID vaccines, particularly the Oxford AstraZeneca vaccine, and blood clots. These are extremely rare, and the Medicines and Healthcare Products Regulatory Agency in the UK is continuing to monitor these adverse effects. It is understandable that you are concerned. So what can you do? If you have headaches that last longer than 3 or 4 days after vaccination, or is severe and persistent, or if you have bruising beyond the site of vaccination after a few days, then we suggest as a precautionary measure to seek medical attention. A few other symptoms that you could look out for as well is any blurred vision, shortness of breath, chest pain, leg pain or swelling, any weakness in your legs or seizures. Then if any of these, if you experience any of these symptoms, then you must seek medical attention. But like I said, this is very rare. Flu-like symptoms and headaches are common, like Dr. Baig has mentioned, and they should resolve within a few hours or a couple of days. So in summary, the benefits of having the vaccine still outweigh the risks. And then lastly, how long to wait after being COVID positive before being vaccinated. So it's important to completely recover from symptoms before you get the vaccine. So in the UK, we recommend you wait at least 4 weeks after testing positive before you get the COVID vaccine. That's everything, and thank you for listening.
Thank you, Tasha. Thank you very much for that. I'm sure a lot of people who are there who have had worries about if their medications allow them to have vaccine or not. You have clarified that, and I thank you most sincerely for that. Moving on, we have the last speaker for the evening, and it is no one but Mrs. Sujata Taladi. She is very well known for her work in charity, but before I talk about her work in charity, let me give you a little bit background of hers. She's a postgraduate in chemistry. While working as a lecturer, she became a TV and a radio announcer. She later set up an IT recruitment business, wrote a weekly column in the Times. She has worked in the charity sector for a very long time. Her mentoring work has been recognized several times with national awards. In 2010, she was instrumental in setting up a Cardiff-based charity called the Mentor Ring. She continues to be the driving force of the charity and is untiring in her efforts to work collaboratively for community cohesion. She is blessed to be able to have inspired many individuals over 2 decades through her work and mentoring others. COVID has had a huge impact on her charity's work. From a more hands-on and face-to-face consultation and care, she had to adopt innovative ways in continuing to provide care and support to the vulnerable and less fortunate in our society. Ladies and gentlemen, I give you the CEO of the Mentoring Ring, Mrs. Sujata Taladi. Over to you, Sujata.
Thank you, Dr. Baig. Good evening, everyone. The non-profit and voluntary sector has been crucial in improving care for people in communities during this time, providing services such as food deliveries and helping to empower and support communities to meet their own needs. The mentoring has assisted in these services. Next slide, please. We are a charity based in Cardiff, Wales, United Kingdom, supporting individuals through mentoring and guiding people of all ages and backgrounds. Next slide, please. We use mentoring as an intervention tool to support individuals in the areas of education, employment, health, and community cohesion on a case-by-case basis. With a critical phase of their lives appended by the pandemic, many have and continue to receive support online through our charity. The number of people we have supported rose dramatically during the pandemic. Next slide, please. It has been an overwhelming experience for the mentoring since the WHO announced the global pandemic. We have learned so many lessons over the past year, such as just being in touch with our beneficiaries that makes them feel that they are not forgotten. The pandemic has changed the way we work and support our beneficiaries, being impacted in an array of issues from technological difficulties to coping with the isolation. Mentoring was always face-to-face with a dedicated mentor to create a more meaningful connection. Next slide, please. However, the restrictions meant, you can see in the slide, it's virtual. The restrictions meant our mentors and mentees could not meet in person. Our walk-in mentoring sessions where individuals could walk into our offices without any prior appointments could not go ahead during the lockdown. We're now using alternative methods such as emails, text, WhatsApp, phone calls, keeping in touch and keeping the lines of communication open. But at times, it's prone to some miscommunication as well. So the mentoring has adapted by creating peer groups and through providing mentoring activities virtually through online platforms like Zoom and Teams. Unfortunately, some services are on pause, such as sports and summer play schemes for children. Next slide, please. Alongside the impacts to beneficiaries' physical health, it has also had profound effects on mental health and well-being. increasing anxiety, stress, and depression. For example, the sudden increase in the redundancies and furlough caused anxiety due to unemployment and financial burden, with others worried about their jobs being lost. Now, shielding resulting in a huge increase in loneliness amongst elderly. Lockdown meant that they couldn't meet their loved ones. And for those who sadly lost loved ones during the pandemic, some social restrictions meant they were not able to give a final and a proper goodbye in hospitals or hold a funeral with family and friends by their side in the normal way. Recognizing the need to offer additional support and positivity, the mentoring as a charity made more regular phone calls through our volunteers than usual so that individuals did not feel that they are not forgotten. Loneliness is the largest reason for referrals in the past year, with others contacting us with financial relationship issues or as parents of newborns. Next slide, please. We are also giving special attention to those with dementia. Our volunteers who visit homes of individuals with dementia help by putting up signs in their homes to assist them, such as signs in the kitchen to remind them to wash their hands, and signs by the front door to remind them to wear face masks when they go out. For dementia carers and family members, we provide as much support as possible, either virtually or over the phone. There is an increasing worry that these carers who are under tremendous stress may end up with mental health struggles due to the emotions of loneliness and depression. Next slide, please. During the pandemic, one of the scenarios we experienced was that members of the community did not understand what was going on with the lockdown and whether they should or should not take the vaccine. So what we did was we reached out to healthcare specialists and news outlets who spoke through a virtual panel format to educate the community, providing the correct information. This was an extremely well-received event. And then as part of the 2021 International Women's Day commemoration, with this year's agenda, Choose to Challenge, we hosted an intimate and impactful evening event with highly accomplished women from a variety of professions, including the NHS and Royal Air Force, to discuss their achievements, experiences, advice, empowerment, and how they are challenging the norms. Finally, to mark a year on from the World Health Organization declaring the global outbreak COVID-19, the mentoring held a virtual event following, allowing the community members to share their stories and their experiences, both positive and sensitive personal stories. That was also well received by the public. Final slide, please. The COVID has affected all of us, both physically and mentally. It has challenged the way we work, the way we live, the way we think. It has particularly affected our elderly, the deprived, and those who have socioeconomic issues living in our communities. Since the pandemic, this COVID has had a devastating effect on our communities. Mental health issues have quadrupled during the lockdown. People are suffering from mental illness and anxiety, depression, loneliness, and the list goes on. How we're going to cope when things get to normal is a huge challenge for all of us. We as a charity are doing as much as we can. Stay in touch. Only together we can all get back to normal, and then we can have a normal life. Thank you for giving me the opportunity to be with you all today. Thank you.
Thank you, Sujata. Ladies and gentlemen, I think her charity needs commending, and the work that this mentoring carries out in our community is very praiseworthy. Thank you for all that you do, and particularly through these difficult times, the way you're looking after people who are suffering. And particularly mental health is the biggest issue these days, one of the biggest issues these days COVID has caused. Good luck with your work, and I'm now going to move on and ask Sean for the questions and answers that have been coming in rather rapidly. And the first question here is, what should I focus on to avoid getting infected with COVID-19? I'll answer that. The most important thing anyone can do is remember the basics: hands, face, and space. Wash your hands, wear your mask, keep your distance. Everyone should continue to follow guidance on washing your hands regularly for 20 seconds, wearing a mask, covering in settings where it is required and where it is difficult to maintain social distancing. Staying 2 meters apart from people you do not live with, or 1 meter with extra precautions such as face covering. And when you are called for your vaccination, please attend and take it. On receiving your first dose, you'll be given an appointment for the second dose. Make sure you have the second dose. Even after vaccination continues, remember the basics: hands, face, and space. Next question, please. Are you immune to COVID-19 if you get it once? How long will the immunity last if one catches COVID-19 or by vaccination? Now, the answer to that is research is still ongoing into how strong that protection is and how long it will last. The WHO is also looking into whether the strength and length of immune response depends on the type of infection a person has. That is, without symptoms or asymptomatic, mild or severe. Even people without symptoms seem to develop an immune response. However, a recent study carried out by Professor Crotty and Sett at the Institute of Immunology in Ohio, USA, it was an in vitro study when they looked at 200 participants over an 8-month period. The findings showed that the immunity memory fades over time. So, as regards the immunity by vaccination, how long it lasts, we do not have any data as yet, but in time, I'm sure we will have answers to this as well. Next question, please. I've already had COVID-19, so I will have immunity to say 6 months when I receive an invitation for my first vaccination. Do you think I should refuse and ask them to give the vaccine to another person who has had no COVID? What is your advice? Dr. Habush, do you want to take this?
Okay, thank you. Thank you, Akram. As you know, people, and you just rightly mentioned this, vary in their response to the immune reaction, be it symptomatic or asymptomatic, and therefore we have to take this into consideration against the fact that vaccines give a consistent degree of immunity and may augment and will certainly augment the already present immune reaction from the infection. So I think, in short, the answer is you should get the vaccine. It is a safe policy.
Okay, next question, please. How likely is it that we would need a yearly vaccination against COVID-19 as we do with the flu vaccine? Husni, do you want to take this again?
I mean, the simple answer, we do not have any confident, robust answers yet, because the opinion of the experts is divided depending on the mutations, which you alluded to in your initial presentation, the variants of the virus, but therefore, and these can escape some degree of immunity or protection from vaccines. So it is as a general rule of thumb, beneficial to receive a booster dose of the vaccine, as happens with the influenza or, with the flu vaccine. And therefore, my simple answer, yes, go ahead. It may be necessary to take the vaccine on yearly basis, but the juries are still out.
Okay, next slide, please. Next question. Are children less likely to get COVID-19 than adults? What is the incidence of children getting long COVID? If so, what are the severe complications of long COVID in general? Benita, do you want to take this, please?
Yes, I'm happy to, Akram. So I think it's difficult because certainly the first wave, we didn't have much information at all on how much children are likely to get COVID. We're not sure if they're less likely to get it. What we do know is that they are much less likely to be seriously ill. They're often much more asymptomatic, or they have a bit of a sniffle and something that people, wouldn't even think was COVID. And so that was the worry that, around children spreading it to adults. That hasn't really played out in reality. There's still a lot we need to learn about this. And in terms of the second question, as I've mentioned in my talk, children are getting long COVID, and some children are really severely affected with multiple body organs, and some are really disabled by the effects. Luckily, it's quite uncommon for children to be that severely ill, but we are seeing it.
Okay, thank you. Next question, please. It is alarming to hear about long COVID and the number of patients suffering from it. What provisional care is available and will need to be provided for the group of patients? Benita, this is up your stream too, please.
Yeah, I think just to reiterate what I said in my talk, it's important that people are heard. It's important people are taken seriously. It's important that investigations are done to make sure it is a diagnosis of exclusion. There isn't something else going on. It's important that somebody who is interested in long COVID sees, as specialist service, sees the patient. But the first port of call is a discussion with the GP, inquiring about what specialist services are in the area. And if your GP doesn't know, there'll be other people who can help you, can find out, and support groups are a really good way of doing this. Okay,
thank you very much. Next question, please. What do I do if I get COVID-19 symptoms? Tasha, do you want to take that?
Yes, thank you. So if you get symptoms of COVID-19 again, you must self-isolate and ask for a COVID test. You can request this online, and there are walk-in centres as well. The symptoms are high temperature, a new continuous cough, body ache, or change or loss of smell or taste. And if you live with someone or someone in your support bubble gets symptoms, again, you must self-isolate as well.
Okay, next question, please. Can the coronavirus disease be transmitted through breastfeeding? Tasha, that's up your stream. Please, can you take this?
Thank you. So currently there's no evidence to suggest that COVID can be passed on through breast milk. The well-recognized benefits of breastfeeding outweigh any potential risks of transmission of coronavirus through breast milk. And the main risk of feeding your baby is the close contact between you and your baby, and not the breastfeeding itself, transmission through breastfeeding.
Thank you. Next question, please. There is widespread reports of blood clots, thrombosis in people vaccinated with AstraZeneca vaccine. What is the truth? Husni, it's up your stream.
Right, thank you very much. There's a recent, yesterday it was reported that there were 79 cases of thrombosis, 19 fatalities, including 19 fatalities, against the use of just over 20 million doses of the vaccine. Now let's put that in perspective. The cerebral vein thrombosis reported with the vaccine is about 4 cases per million, against a natural background of 3 cases per million. That also means that the death rate from this condition after AstraZeneca vaccine is 1 per million. Let's compare that to COVID, which causes 30 deaths per million infection-wise. So the difference is very, very significant. That's number one. Number two, we do not know the actual circumstances of these events. They're collected together, lumped together, but we do not know what triggered or what were the actual event, how the actual events occurred. These were investigated or explored by the British Society for Hematology, the European Medical Association, and the American Society for Hematology, and all agreed that the AstraZeneca vaccine is a safe vaccine, and the incidence of these events is a very, very small and rare one.
Okay. Next question, please. What are the chances of me getting an anaphylactic reaction? How will I be treated if I get a reaction? Is that for you, Benita?
Yeah, I'm happy to take this. So the chances of having an anaphylactic reaction are extremely small. And the advice is that the only contraindication to taking the vaccine at the moment is if you have had a previous anaphylaxis to one of the very specific ingredients in the vaccine. And again, there's been more than 20 million of these vaccines given in this country, and an absolute handful of anaphylactic reactions, none that we've not been able to treat. And there is standard treatment available in all vaccination centres with people who are trained to deal with anaphylaxis with adrenaline and nebulizers and antihistamine type drugs. So it is a treatable condition. It can be serious, but it's extremely rare, and it shouldn't put you off having the vaccine unless you've had an anaphylaxis to a very specific ingredient. And in all vaccination centres, we're keeping an eye on people for at least 15 minutes, 30 minutes after the vaccine, if they've had a previous reaction of some sort, as a safety net as well.
Thank you. Thank you for that. Next slide, please. Next question, please. Sean?
Yeah, it's on the screen, Akram. Question 11.
Right, okay. So why is Pfizer vaccine stored at -70 degrees and AstraZeneca vaccine at refrigerated temperature? I'll start by talking about the AstraZeneca vaccine first. This is a viral vector vaccine, and it remains stable and does not deteriorate at a refrigerated temperature. Now, it's a different story with the Pfizer vaccine. It's a new technology in which genetically engineered RNA, mRNA, is used to generate a protein that will safely prompt an immune response. The mRNA used is so delicate that it has to be protected by a nanoparticle of a lipid capsule. It is surrounded by this lipid capsule, and in order for this lipid capsule to safely deliver this vaccine when injected, has to be kept at -70 degrees. And that is the rationale why it has to be kept at -70 degrees. Okay? I hope that answers the question. Next question. Right. Whenever we hear the Prime Minister or scientific advisors giving a report, they talk about the R number. What is the R number, and why is the R number above 1 dangerous? The R number is a way of rating coronavirus or any disease ability to spread. The R is the number of people that one infected person will pass on a virus to on average. Measles, for example, has an R number of 15 in population without immunity. That means, on average, one person will spread measles to 15 others. So, coronavirus, the COVID-19, would have a reproduction number of about 3. If no action was taken to stop its spreading, then it will spread violently. Why? The next question is, why is the R number above 1 dangerous? If the R number value is higher than 1, then the number of cases increases. But if the R number is lower, the disease will eventually stop spreading because not enough new people are being infected to sustain the outbreak. And that is why it's got to be below 1. I hope that answers the question. Are there any new drugs developed by pharmaceutical company which can treat COVID-19? Yes, there are some drugs which may be repurposed as viral trials of these have not started, or if they are, we don't know about them. If we had a drug, for example, which works against SARS-CoV-2, this is hypothetical, that anyone can take that drug as soon as symptoms start, so that to stop the virus from replicating, and they will hopefully improve. As importantly as that, the virus will not be secreting in their respiratory tract, and the individual will not be transmitting the virus through droplet or aerosol transmission. However, this is the point to listen to. We know that Pfizer has started a novel antiviral drug trial. The drug is in phase 1 trial. It is a protease inhibitor and acts by binding to the viral enzyme protease, which stops the virus from replicating. The company hopes that it will be available for use by the end of the year. So when it comes on the market, we can go and get this protease, put it in. Bob is your uncle. Next slide, please. Tasha, do you want to take this? Can anyone tell us about the vaccination passports, COVID certificate, how this is going to be used and its implications, please?
Thank you. So COVID certificate pilots will begin shortly as announced by the Prime Minister. COVID certificates are going to be developed over the coming months and may be used for some big events. But at the moment, it's not needed for going to the hairdressers, for shops or pubs in England. And before we come up with something like this, I think that there's going to be a vote, MPs vote on vaccine passports. So it's not there yet, but we need to watch the space and see what happens.
Okay. Last, I think this is the question, Zilla. Will the vaccine end the pandemic? Okay. Look, I was reading this article. On the 11th of January 2021, the International Federation of Red Cross and Red Crescent Society, they gave a press release in which they said that the COVID-19 vaccine will roll out across many countries. The world's largest humanitarian network is once again warning that the vaccine alone will not end the pandemic. Since then, press release, a lot has changed. We now have the virus mutating and throwing variants at us, which some of them escape the vaccine. And we may see these variants continue to infect people. There are also the anti-vax in our community who are not going to have the vaccine. This does not help the present pandemic. People need to remain vigilant, continue to adhere to basic preventative measures that include physical distancing, wearing the mask, hand washing, and when invited to have the vaccine, to please take it. Next question, please. Right. Why are the vials of vaccine delivered in 5 ml and not pre-filled syringes, as it will make it quicker to administer and time saving? Very, very good question. At the moment, in the UK, we have 3 approved vaccines. It's the AstraZeneca, the Pfizer, and the Moderna very recently. They are all delivered in 5 ml vials. The glass vials they are using is for a good reason. As it is a special class of glass, it is made of borosalicylate. Okay? This glass is chemically inert material and does not react with the constituents of the vaccine, and the vaccine remains unchanged, and that is the reason why they are using vials. Thank you. Next slide, please. Or next question. Right, that's the end.
Well, Akram, thank you so much. We have a load of other questions, but I think due to time,
okay,
I think we're going to have to call it a day.
Right. So let me just finish off then, Sean.
Sure. Yep.
Ladies and gentlemen, I trust what you have heard has been beneficial to you. What you have heard about the virus is just the beginning. I feel and hear from experts that the virus is here to stay for some time. We all have to brace ourselves and be subjected to the wrath of this invisible killer for years to come. There are many amongst us who still think this virus is a joke. Of many who have listened in tonight, there may be some who have doubts about taking the vaccine. Hopefully, tonight's various talks have at least persuaded some to take the vaccine. I'm hoping, the Grand Secretary is gone, but I'm hoping with his blessing of the Grand Secretary to be able to, with my team, to present a follow-up talk in about a month or 6 weeks' time. And the aspects that will be covered in that talk will be things that have not been covered in this lecture. Thank you all for listening, and I'll be delighted to have your feedback by email, drbaig@sky.com. But in the meanwhile, before I go, I'm going to ask Sean to say a few words, but on my behalf and for my team's behalf, thank you all for listening to us. Please continue with the space, the washing of your hands. I wish you well, and please keep safe. Keep safe. Over to you, Sean.
Thank you so much, Akram. That was, I'm sure I speak on behalf of everyone who's come along and attended tonight, a really informative and fascinating presentation on what has obviously been the biggest challenge of all of our lives so far, and certainly of our generation, and hopefully something that once we do get a grip on it, if we get a grip on it, that we'll only experience once in our lifetimes. I think I speak for everyone when I say that we've learned a lot. So Dr. Baig, Dr. Habush, Dr. Kane, Natasha and Sujatha, thank you very much from all of us at UGLE for taking the time to come and speak to us and inform and educate us on this vitally important topic. To all of you that attended, thank you so much for taking the time out of your evenings to come and find out more and to learn with us from this expert panel on such an important topic. We hope that you found it informative. I'll just repeat what I said at the beginning. The meeting has been recorded. It will be shared in the next edition of The First Rising, which will be coming out on Monday in a couple of weeks' time. So look out for it there. It will also be shared on UGLE's social media platforms after that date. So please do, when you see it, share the link, spread it around. As I'm sure you'll agree, there's some absolutely vital information in there, potentially life-saving information in there for people to learn and find out. So once again, on behalf of all of us at UGLE, to Akram and his team, thank you so much. And to all of you, good night and stay safe. Goodbye, everybody.
Thank you, Sean. Thank you, everybody. Thank you, Benita. Thank you, Husni. Thank you, Serge, and thank you, Asha.